Welcome everyone to the Better Breathing Institute webinar series. Thank you all for attending. Today I'm absolutely delighted to have Daniel Craighead on the webinar. Daniel is an assistant professor in exercise physiology at the University of Minnesota. His area of research revolves around why the cardiovascular system becomes dysfunctional with aging and disease, and novel ways to overcome this. One of his greatest research accolades has been investigating high-resistance inspiratory muscle strength training and the impact on lowering blood pressure and improving health. The results from this work have been published widely, including coverage on National Public Radio, NPR, and the University of Colorado. Daniel, thank you for your time today. We really look forward to learning more about your research and the application of IMT as a lifestyle strategy for improving cardiovascular health with aging. I'll leave it to you now, Daniel. Thank you.
Great. Well, thank you very much for that introduction, and thank you for everyone for joining us today. Before I get started kind of with the meat of my webinar, I'm just going to tell you a little bit more about myself. So for 7 years, I was a researcher at the University of Colorado Boulder in the Integrative Physiology of Aging Laboratory. So I started there as a postdoctoral fellow and then transitioned to the role of assistant research professor. And much of the research that I'm going to present to you today was conducted while I was in Colorado. That's why you'll see a lot of the color scheme using the Colorado black and gold. But then last year, I moved institutions and started my own laboratory, the Integrative Cardiovascular and Exercise Physiology Laboratory at the University of Minnesota in Minneapolis. And when we get near the end of the webinar, and I start telling you about kind of ongoing and future research projects, a lot of that is work coming out of my new laboratory. So that's a little bit about my sort of recent academic journey, where the research you're going to see has and will be taking place. So let's now transition into the webinar. Here's an outline of everything that I'm going to discuss today. I'll start by giving you an overview of cardiovascular diseases, aging, and hypertension. So sort of setting the stage for why cardiovascular disease is something important that we need to be able to prevent and treat. I'll then tell you about my research to date on high-resistance inspiratory muscle strength training, or IMST for short. Then go into IMST for improving cardiovascular health before ending with future directions. So where, what do we know and where are we going next with research on IMST, with a specific focus on how do we translate this out of the laboratory and into the public health domain. So let's get started with some background on cardiovascular diseases, aging, and hypertension. So when we talk about cardiovascular diseases, or CVD for short, we're combining a number of conditions that impact the heart and blood vessels. So we're talking about things like coronary heart disease, heart failure, cerebrovascular disease, which is disease of the blood vessels in the brain, peripheral artery disease, deep vein thrombosis, for example, as well as cardiovascular events such as heart attacks and strokes. And when we think about all of these conditions together, cardiovascular diseases are the leading cause of death worldwide. So this figure on the left shows data from the United States, but the trend is broadly applicable around the globe. It shows the percent of total deaths from cardiovascular diseases in gold, as well as other leading causes of death like cancer, respiratory conditions, accidents, etc. in black. And what you can appreciate is that cardiovascular diseases are the leading cause of death, contributing to more deaths than all the other leading causes. So because it's the leading cause of death, combating cardiovascular disease is really an important public health priority. Now, cardiovascular diseases really are a condition of aging. This figure on the right now shows you the percent of the US population diagnosed with a cardiovascular disease, binned into different age groups along the x-axis. At younger ages, so kind of in this 20 to 39 year age bracket, almost nobody has a cardiovascular disease. The prevalence is very low. With increasing age, though, the prevalence increases dramatically, such that by midlife or older adulthood, a really high proportion of the population is diagnosed with a cardiovascular disease. Now, if you know anything about the changing population demographics, you know that the number of midlife and older adults is rapidly increasing. So as we get more and more adults living to older ages, that predicts an increased burden of cardiovascular disease unless effective therapies are established to prevent cardiovascular diseases. So what are some processes linking cardiovascular disease and aging? Because if we can target those processes, potentially we can prevent cardiovascular diseases. One of the main processes is hypertension or high blood pressure. So high blood pressure is a risk factor for cardiovascular diseases. And this figure shows you the percent of people diagnosed with hypertension defined as a systolic blood pressure of at least 130 millimeters mercury, so that's the top number in a blood pressure reading, or a diastolic blood pressure of at least 80 millimeters mercury, that's the bottom number. Again, we're binned into different age groups, and men are shown in the black bars and women in gold. Like the prevalence of cardiovascular diseases, the prevalence of hypertension also increases with advancing age. However, at any given age, the prevalence of hypertension significantly exceeds cardiovascular disease prevalence, such that by midlife, so kind of this 45 to 54-year-old age bracket, already a majority of adults have hypertension, and by older ages, almost everyone has blood pressure above that healthy recommended level. So hypertension is a really highly prevalent chronic condition that increases the risk for cardiovascular disease. And when we put it all together, we get an experimental model that looks like this. Aging is associated with an increase in blood pressure that is one of the driving factors for cardiovascular diseases. So if we can target blood pressure, potentially we can prevent cardiovascular diseases. Given the high prevalence of high blood pressure, hypertension is the #1 modifiable risk factor for cardiovascular diseases. Now, hypertension is not a new condition. We have a number of established therapies to lower blood pressure. So there's established pharmacotherapies, things like angiotensin converting enzyme inhibitors or diuretics that have been shown to lower blood pressure. There's also established lifestyle therapies, so aerobic exercise, maintaining a healthy body weight, or reducing dietary sodium, for example, are all things that we know will help control blood pressure. However, despite having these established pharmacotherapies and lifestyle therapies, over 3/4 of adults who have hypertension fail to adequately control their blood pressure. And this rate of blood pressure control is not improving. We're sort of stuck at this really suboptimal level of control. So there's definitely a need for novel therapies that can lower blood pressure and contribute to reducing cardiovascular disease risk with aging. So that is where inspiratory muscle training, or specifically high resistance inspiratory muscle strength training, comes into play as something I've been researching as a potential way to lower blood pressure and reduce cardiovascular disease risk. So high resistance inspiratory muscle strength training, or IMST, involves breathing in through a device that provides resistance when you inhale. So in this way, it acts like strength training that specifically targets the diaphragm and the accessory inspiratory muscles. Expiration is unimpeded. Now, this figure in the middle compares the resistance applied with IMST compared to some other kind of conventional activities. On the y-axis, we have percent maximal inspiratory pressure. So a value of 100 would indicate the most pressure that you could produce while breathing in. At resting tidal breathing, which is probably what most of you are doing right now, your respiratory muscles are producing only a very, very small fraction of the total force that they could produce. So they're not working very hard to just breathe in at rest. Slow, deep, meditative breathing requires about double the inspiratory effort of resting tidal breathing, but is still using only a small fraction of your maximal inspiratory pressure. Next, we have maximal intensity aerobic exercise. So think about running or cycling as hard as you can and the level of inspiratory force produced during activities like that. During these activities, you have to produce significantly more inspiratory force than kind of resting or slow, deep meditative breathing, but you're still only getting up to 30% maximal inspiratory pressure. So there's this large reserve between what your respiratory muscles can produce and what they're asked to produce during even the most high intensity forms of exercise. This is where IMST comes into play. We set the resistance on these devices to 75% maximal inspiratory pressure. So that's 2 to 3 times greater than that achieved during even maximal intensity aerobic exercise. So it's not something that you come across in day-to-day life, making it a really unique physiological stimulus that may have health benefits that aren't achieved through other sorts of therapies. A trade-off of making the intensity so high is that we can also reduce the duration of training. So we have people do high resistance IMST at 75% maximal inspiratory pressure. We ask them to only do 30 resisted breaths in a session, which takes a little over 5 minutes to complete, making it very time efficient. And we think that time efficiency is key, and I'm going to tell you why. So to explain the importance of that time efficiency, we're going to go back to our sort of experimental model where we have aging leading to high blood pressure and then cardiovascular diseases. And we're going to compare high resistance IMST to a more established form of exercise, moderate intensity aerobic exercise. So things like walking, running, swimming, cycling, etc. Current guidelines call for accumulating 150 to 300 minutes per week of aerobic exercise. And we know that if people are able to achieve those volumes of aerobic exercise, their blood pressure will go down. And through that, as well as some other health benefits of aerobic exercise, cardiovascular disease risk will decline. However, despite knowing that aerobic exercise is effective, rates of adherence to actually meeting aerobic exercise guidelines are really poor. At most, about 40% of adults actually accumulate enough aerobic exercise each week to meet these guidelines. And some estimates suggest significantly lower rates of adherence, maybe as low as 10 to 15%. So a lot of people can't or won't perform enough aerobic exercise to get all the cardiovascular health benefits. When asked why, the most common reported barrier is time availability. So people say they don't have enough time in the day to perform 30 minutes to an hour of aerobic exercise. Other common barriers include things like cost associated with exercise equipment or gym memberships, or maybe transportation issues if you don't live somewhere with a nice built environment for outdoor recreation nearby and you have to travel. That can be an additional barrier as well. So there's a lot of things contributing to suboptimal adherence to aerobic exercise guidelines. In contrast, high resistance IMST is time efficient. Remember, it takes just over 5 minutes a day to complete, so it can be done without a big time burden. It's also done using a small portable handheld device, so it can easily be done at home or done during travel. And when you compare it to purchases like a treadmill or other home exercise equipment or a monthly gym membership, it's relatively inexpensive as well. So if high resistance IMST can have similar blood pressure lowering effects as aerobic exercise, it has a lot of potential for translation into public health implementation because it gets over a lot of these barriers that people experience to accumulating enough aerobic exercise each week. So is there any actual evidence, though, that high resistance IMST can lower blood pressure? Well, right before I started at the University of Colorado, research from Dr. Jennifer Vranish and Dr. Fiona Bailey at the University of Arizona came out, where they tested 6 weeks of high resistance IMST, so 30 breaths a day at 75% maximal inspiratory pressure, for improving sleep apnea. A sleep apnea is a condition where people stop breathing for periods at night, so it makes intuitive sense that a respiratory intervention would potentially be able to improve this respiratory condition. Interestingly, Doctors Vranish and Bailey didn't really see much of an improvement in sleep apnea symptoms, but they saw clinically significant reductions in blood pressure. So we saw these results and were interested, were these reductions in blood pressure something that only happens in sleep apnea patients, so it's something specific to this patient group? Or can it be translated to generally healthy adults with high blood pressure, knowing that kind of that represents a majority of adults in midlife and older adulthood. And if it is effective in these adults, it could be something broadly applicable for improving cardiovascular health. I also wanted to know if it could lower blood pressure, could it have benefits on some other important markers of cardiovascular disease risk? So along with blood pressure, I also wanted to look directly at the health of blood vessels in two ways. So one is looking at arterial stiffness, and the other is looking at vascular endothelial function. So arterial stiffness involves how stiff your arteries are. So we want our arteries to be nice and compliant, meaning they can expand and recoil with each heartbeat. And that kind of helps smooth out our blood flow so that when blood gets to our delicate organs like our brain, our eyes, and our kidneys, instead of being hit by pulsatile pressure, they get nice smooth pressure, which is what those delicate organs want. Endothelial cells form the inner lining of your blood vessels, and they're really important for producing chemicals that prevent cardiovascular disease onset. Now, with aging and in some disease conditions, arterial stiffness goes up and endothelial function goes down. So as arterial stiffness increases, more pressure is placed on the heart, and the arteries lose their ability to expand and recoil, leading to increased pulsatile pressure to the organs, which can damage a lot of other organs in your body. The health of endothelial cells goes down, and that leads to plaque buildup in the arteries, increasing cardiovascular disease risk. So we suspected if IMST could lower blood pressure, it may have impacts on other parts of the cardiovascular system related to cardiovascular disease risk. So we wanted to know, is IMST effective in generally healthy adults with high blood pressure, and will it impact these other important health markers? So to do this, we launched a double-blind, randomized, sham-controlled, parallel design clinical trial. We recruited adults who were ages 50 to 79 and had a systolic blood pressure of at least 120 millimeters mercury. So they didn't necessarily have to have hypertension, but 120 millimeters mercury is considered normal. So they had to be at least kind of above normal, where you start getting cardiovascular health complications from blood pressure. Our main outcome was systolic blood pressure, because with aging, systolic blood pressure tends to keep going up, whereas diastolic blood pressure actually goes down. However, we did also look at diastolic blood pressure, the health of the endothelial cells, as well as arterial stiffness. And then we were interested in what's actually happening. What are the mechanisms through which these cardiovascular health markers may be improving? So this figure shows the design of our study. We recruited and screened participants to make sure that they were the right age and had blood pressure in the right range, but were otherwise generally healthy. They went through baseline testing for blood pressure and blood vessel health, and then they were randomized into two groups. So one group, our IMST treatment group, did 30 resisted breaths per day, 6 days per week, at an intensity equivalent to 75% of their maximal inspiratory pressure, or PI max. And they did that for 6 weeks. 5 of their 6 training sessions per week were done unsupervised at home. And 1 training session per week, they came back to the laboratory and they did a supervised training session with an unblinded research assistant. And that research assistant reassessed their maximal inspiratory pressure and reset the training intensity. As people improved, they started training at higher levels. The other group was a low-resistance sham control group that went through the exact same training procedure, but with the intensity of their training device set to only 15% of maximal inspiratory pressure. So this allowed them to still get some resistance when they were breathing in, which let them believe they were getting a healthy lifestyle intervention. But we didn't think only 30 breaths per day at this low intensity would be enough to actually elicit improvements in cardiovascular health. Then after 6 weeks, they came back, we reassessed the cardiovascular system, and then we actually took their training devices away and had them return to their previous lifestyle for 6 weeks. So they abstained from IMST for 6 weeks, at which point we brought them back once more and assessed their blood pressure to see if the potential effects were long-lasting. So for this trial, we consented 64 participants, of which 38 were ultimately randomized evenly between our IMST and sham control groups. We lost 1 person in each group, 1 person in the IMST group with an injury unrelated to inspiratory muscle training. And in the sham group, we had one person who had a drastic change in diet. They decided to go on an all liquid diet halfway through, which was going to impact their results, so we had to remove them. That left us with 18 participants in each group for our main analysis to see what happened after 6 weeks of IMST. And then 29 participants agreed to come back for that 6-week follow-up time point after abstaining from IMST to see if there were any long-lasting effects. So we'll get to the cardiovascular benefits in a minute, but I'm going to start by telling you just some quick results. We found that 6 weeks of high-resistance IMST was an effective training stimulus, so their maximal inspiratory pressure went up by about 20%, indicating that there was an increase in respiratory muscle strength. It was safe. There were no serious adverse events, and there were only 2 minor adverse events in the IMST group. One was kind of neck muscle soreness, and the other was transient lightheadedness with training. Both of these adverse events occurred early in the 6-week training program and resolved without treatment. IMST was tolerable, so nobody dropped out due to adverse events. And it promoted adherence. So participants completed 94% of their prescribed training sessions at the appropriate intensity. Now, they did have regular interaction with investigators during this study, so we expect adherence to be high, but it's at least a good starting point knowing that there's the potential for high rates of adherence to IMST. So now let's get into the cardiovascular benefits. On the left here, we have a figure showing you the change in systolic blood pressure with our study. I'm going to take a second to orient you to the figure because I'm going to use a similar figure diagram throughout all the results I show you in this talk. So on the y-axis, we have systolic blood pressure. We have black bars indicating baseline data, so before training in both the sham group and the IMST. So black bars labeled pre indicate how they were before enrolling into the study. The gray bars show the data for our sham control group after 6 weeks of sham training, whereas the gold bars indicate the data from our IMST treatment group after 6 weeks of IMST. And we'll use that same design as I show you more data. Now, in the sham group, there was no change in systolic blood pressure with 6 weeks of training. With IMST, on contrast, we saw a 9 millimeter mercury reduction in resting systolic blood pressure. So this was statistically significant. And more importantly, a change in blood pressure of that magnitude is clinically significant. If a blood pressure of this size is maintained in the long term, it would be associated with about a 30% lower risk for cardiovascular diseases. So potentially it could have a really big impact on public health. That compares favorably to things like aerobic exercise. So it's at least as large, if not larger than what's seen on average in blood pressure reductions with aerobic exercise. And again, achieved with about a 35 minute per week weekly time commitment versus a 150 to 300 minute per week commitment for aerobic exercise. It also compares nicely to pharmacotherapies, so medications that are prescribed to lower blood pressure. So really promising results there for the impact of IMST on systolic blood pressure. The figure on the right shows you the results for diastolic blood pressure. Again, there was no change in the sham control group in diastolic blood pressure, and there was a small but statistically significant 2 millimeter mercury reduction in diastolic blood pressure with IMST. And this occurred despite our participants having normal diastolic blood pressure on average at baseline. So while it's not as high of a magnitude of reduction, it's still a promising finding suggesting that IMST can reduce diastolic blood pressure as well. Now remember, this study included this follow-up testing time point where we brought people back 6 weeks later. This figure shows you the data from the 29 participants who completed all 3 testing time points, and the follow-up testing data are shown in these hatched bars. There was no change in systolic blood pressure at any time point in the sham control group. With the IMST group, we see this same 9 millimeter mercury reduction in systolic blood pressure. And then interestingly, 6 weeks later, so after no training, the reductions in systolic blood pressure was about 3/4 maintained and still lower relative to baseline. So this suggests that the blood pressure lowering effects of IMST are long-lasting. Now, we definitely need to confirm this finding in other trials, but if it is shown to be reproducible, it could be really beneficial, as potentially you could just do IMST intermittently to keep blood pressure under control, and that could have positive effects for adherence as well. This was a really surprising finding because other blood pressure lowering therapies, like medications, like aerobic exercise, do not exhibit these same long-lasting effects. So if you stop taking your medications or stop regular physical activity, blood pressure rebounds to the initial high levels very quickly. Interestingly, similar long-lasting effects have been seen with kind of slow, deep breathing interventions. So potentially there's something about the respiratory system and it being a respiratory intervention that contributes to these long-lasting effects. We did not see the same sort of long-term effect on that small reduction in diastolic blood pressure, but overall, some very promising findings for the impact of IMST on blood pressure. Next, we'll get into vascular endothelial function. So if you remember, I told you that the endothelial cells form the inner lining of our blood vessels and produce chemicals that are really important for preventing cardiovascular diseases. One of those chemicals is called nitric oxide, or NO. So we want our endothelial cells to be able to produce a lot of nitric oxide. A way we assess this in people is with a test called brachial artery flow-mediated dilation, or just FMD for short. So for FMD, we use an ultrasound to measure the diameter of someone's brachial artery at rest, and then we inflate a cuff on their arm to suprasystolic pressure, so we're occluding blood flow into their arm for 5 minutes. After 5 minutes, we deflate the pressure in this cuff, and that causes blood to rush through the brachial artery back into the arm to reperfuse the arm with blood. And that rush of blood through the brachial artery acts on the endothelial cells and causes them to produce nitric oxide. And that nitric oxide makes the brachial artery dilate or get wider. So we measure how much wider the brachial artery gets, and that tells us how much more nitric oxide is being produced. So we look at the change in brachial artery diameter, and every 1% higher change in diameter, so more dilation, is associated with about a 10% lower risk for cardiovascular disease. So this figure shows you the results from our FMD test in our IMST study. There was no change in endothelial function in our sham control group, but there was a significant increase in FMD in our IMST treatment group. The units on the y-axis are percent change in brachial artery diameter, and this difference is about a 2.5% change. So compared that to what I just told you about a 1% increase being associated with a 10% lower risk for cardiovascular disease, here we're seeing 2.5% increase, so that's likely to also be associated with a significant reduction in cardiovascular disease risk. So a really promising finding that IMST not only lowers blood pressure, but directly improves the health of our blood vessels. Now, we wanted to look at this a little more closely and see, can we look at nitric oxide more directly and see if that is going up? So for that, we used a cell culture model where we took human umbilical vein endothelial cells. So these are endothelial cells similar to what's in our blood vessels. And we grew them in culture with serum sampled from our participants before and after 6 weeks of IMST or sham training. So in this way, we're basically recreating the internal environment in which our study participants' endothelial cells were exposed to. And now we're able to look at the endothelial cells directly and see if the amount of nitric oxide they produce has changed. So we cultured these endothelial cells in serum and measured how much nitric oxide they made. We actually saw that serum taken after sham training caused a very slight increase in nitric oxide production, which would be a beneficial finding. But we found that endothelial cells cultured with serum after IMST caused a significantly greater increase in nitric oxide. So this largely matches those tests we did in people, that FMD test where we squeeze their arm, and suggest that yes, IMST does do something that increases nitric oxide, which is really important for preventing cardiovascular diseases. One of the main things that changes with aging to reduce nitric oxide and impair the health of our endothelial cells is an increase in oxidative stress. So if you've heard about oxidative stress or free radicals, those tend to increase with aging and are bad for endothelial cells. So we also use this model to look at how much of a free radical called superoxide is produced in endothelial cells. And that's shown in this figure on the right. So we actually saw some increased reactive oxygen species production in the sham-treated cells, which would be a negative finding. We want less oxidative stress. With IMST, we saw a significant reduction in oxidative stress in endothelial cells treated with plasma taken after IMST. So combined, this tells us that IMST is able to reduce oxidative stress, and that's a likely mechanism through which nitric oxide goes up and the health of our endothelial cells improves. Because we're able to get these results using just plasma taken from our participants, it also suggests that something is actually changing in the circulation. So something is being added or removed from blood when you do IMST, and that something has impacts on the vasculature. So very interesting and something we're looking at more to see what's actually changing in circulation. The last thing we really were focused on looking at was arterial stiffness, that other measure of cardiovascular health that's really important. And while we had positive effects on blood pressure and endothelial function, we saw no impact of IMST on arterial stiffness. So we'd want to see a reduction. We didn't see that. That's not too surprising. Arterial stiffness tends to be much less malleable than things like blood pressure and endothelial cell health. So with conventional aerobic exercise, it often takes at least 3 months in order to lower arterial stiffness. So it's not too surprising that a relatively short 6-week intervention was unable to change arterial stiffness. So those were our main cardiovascular outcomes. And I'm just going to tease you with that we did look at a lot of other things in this study and published some follow-up papers on our secondary outcomes. So if you're interested in exercise performance or physical performance, we put our participants through treadmill exercise tests before and after this intervention. And we found that people in the IMST group were able to exercise longer on treadmill, about 10 to 15% longer after 6 weeks of IMST versus our sham group. These people we had in our study were already fairly active people. Most of them were actually meeting physical activity guidelines. So it wasn't like they were largely detrained. IMST had this positive and fairly robust effect on exercise performance, even in people already being physically active, which I think speaks to the strength of it as a stimulus for improving exercise performance. So that was another positive finding. And then in a subset of our people, we expanded our measures of cardiovascular health to actually look at blood vessels in the brain and found that these same benefits that we saw kind of in the peripheral vasculature extend to the brain blood vessels as well. That's really important because a change in brain blood vessel health is associated with risk for stroke, as well as increase for cognitive decline and dementia. So potentially, IMST could have really important impacts on brain health as well. Now, I've shown you results from just a single study, and I want to show you some stronger evidence supporting the blood pressure lowering effects of IMST to hopefully convince you even more strongly of its cardiovascular health benefits. So we collaborated with Dr. Fiona Bailey at the University of Arizona, who I told you kind of was the person who created this intervention when looking at obstructive sleep apnea patients. So by 2022, Dr. Bailey had done multiple other studies in obstructive sleep apnea patients as well as young, healthy adults. All of her studies, as well as the study we completed, all used the same 6-week IMST intervention with 30 breaths per day, 75% maximal inspiratory pressure. And so because we used this same study design, we were able to pool all the data we'd collected together in a multi-site, multi-trial kind of retrospective analysis of the blood pressure lowering effects of IMST. So we did that with Dr. Bailey and her postdoc at the time, Dr. Dallin Tavoian, to really get a stronger picture on what can IMST do for blood pressure. And the results are summarized in this figure on the right. So on the top, we have systolic blood pressure, and on the bottom, we have diastolic blood pressure. On average, systolic blood pressure went down by 9 millimeters mercury, where there was no change in our sham control group. And diastolic blood pressure went down by 4 millimeters mercury, again with no change in the sham group. We were able to look at the time course of changes in this study as well. And you can appreciate that systolic blood pressure and diastolic blood pressure started going down in as little as 2 weeks of training. So the effects on blood pressure seem to occur fairly rapidly. And if you look at these trends in blood pressure, you see that it appears there's still a downward trend after 6 weeks of training. So potentially with longer interventions, we would see even greater blood pressure reductions. Because we had a larger subject population, we also were able to look at important things like age, baseline blood pressure status, previous use of antihypertensive medications, and see if they impacted the effectiveness of IMST on blood pressure. And really what we found was that those things, age, where your blood pressure was at the start, if you were using meds, had really only a small impact on how well IMST worked. So it seems to be largely effective across kind of a broad population of people, which was pretty exciting. So that kind of summarizes what we've done to date. Hopefully, I've convinced you that IMST is safe and tolerable. When done in the laboratory, it promotes adherence and is effective at lowering blood pressure. We also have data suggesting that it improves vascular endothelial function and does this by increasing nitric oxide bioavailability and decreasing oxidative stress. So that's a lot of exciting results that I think speak to the strength of this intervention as something for improving cardiovascular health. But I think there's still a lot that we need to know. So I'm going to finish this talk by telling you about some kind of current and future research areas on IMST. So what's going on right now with IMST research? Well, after completing that initial clinical trial, I launched a new study, which is described in this diagram. It looks relatively similar to the study I described to you previously, but has some key differences. While we're still using the 30 breaths per day IMST intervention, our comparison group is no longer a low resistance sham control group. We're now comparing IMST to aerobic exercise, so 150 minutes per week of brisk walking. So that would be kind of meeting the minimum guidelines for aerobic exercise. So now we'll be able to see how well does IMST work at lowering blood pressure when directly compared to an established guideline-based healthy lifestyle intervention. We're also using a longer now 3-month treatment duration. So if the intervention really is more effective with a longer training period, we'll see that now as we've doubled the length of training. It also maybe will let us see changes in things like arterial stiffness that we didn't see changes in our initial study. And finally, this study will be significantly larger, hopefully closer to 100 participants rather than the 36 participants we had in our pilot trial. So this should provide some really definitive evidence on the cardiovascular health benefits of IMST in a controlled laboratory setting. So we're getting near the end of this study. It's included adults ages 50 years and older who have a systolic blood pressure of at least 120. We're again looking at blood pressure and vascular endothelial function. And because of the potential brain benefits we saw, we're looking more closely at cerebrovascular function, so doing some more robust measures of brain blood vessel health, as well as doing cognitive tests, and then some additional mechanisms of action. So because this is an ongoing blinded randomized trial, we don't have results yet, but keep your eye out and hopefully in the near future we'll have results for you. Another thing that we're doing is trying to figure out the best IMST intervention for improving cardiovascular health. So if you've been paying attention, all the studies I've described to date have used this 30 breaths per day, 75% maximal inspiratory pressure resistance training program. So we think that works, right? We've repeated it across multiple studies. It seems to be an appropriate healthy lifestyle intervention, but we don't know if this is the best intervention or not for improving health. So we're just now launching a new study where we're comparing IMST with 3 different training protocols. So we're using our 30 breaths per day established intervention as kind of our control. And then we're going to increase and decrease the dose. So we'll have one group performing 45 breaths a day and another group performing only 15 breaths per day. Potentially, we'll see an even greater reduction in blood pressure with a greater training stimulus, which could indicate that there's a way we could change this protocol and get even better improvements in cardiovascular health. Or potentially with the 15 breaths per day group, we'll see that there's benefits of even that minimized training program, which could help boost adherence even more. We'll see. But we're starting to explore, are there ways we can tailor this training to improve the effectiveness. This study launched after our retrospective analysis done in conjunction with Dr. Bailey, and now we know that IMST really is effective in adults of all ages, not just midlife and older adults. So we're including adults age 18 years and older in this study who have above normal systolic blood pressure, with a real focus on blood pressure, vascular endothelial function, and then acute and chronic metabolomics, which is a way of saying we'll be looking actually at what's changing in the circulation as people do this training to figure out what's in the blood that might be stimulating these health benefits. So those are a few studies I currently have going on. There's a lot more studies happening that I don't have as much time to tell you about in detail, but just kind of to give you a preview of other things to keep your eye on. There's ongoing efficacy studies, by which I mean laboratory-based clinical trials, which all the studies I've told you about thus far are, on IMST in patients with chronic kidney disease, patients with obstructive sleep apnea, people with long COVID, as well as more. So investigators all over the world have really taken this intervention and are trying to find out all the different groups that it can be effective for improving cardiovascular health and other important health areas of physiology. So exciting time for this intervention. The next thing we need to do is take IMST and move it out of these laboratory-based clinical trials, right? In these controlled settings, we can establish if the intervention works under ideal settings, but next we need to know, does it work in the real world when people do this on their own without a study investigator walking them through it, keeping them accountable? And I think now is a good time for that. Because based on the level of evidence we have, we can be fairly certain that IMST is safe, has only some minor adverse events, promotes excellent adherence, at least in our laboratory studies, is low burden, so doesn't take a lot of time or a high financial cost, and has the potential to cause clinically significant reductions in blood pressure. So because there's a lot of potential benefits and not a lot of risk, now I think is a good time to start moving towards public health implementation. And a way to do that would be through a smartphone app that could take the place of investigators, deliver the IMST intervention, as well as help people monitor their blood pressure as a way to get this out of the laboratory and more back into widespread where everyone can use it. So we actually recently completed a series of focus groups with potential target app users. So these are people who have high blood pressure and want to get it under control. So we discussed with these people, is IMST through an app something that you would be interested in? And they expressed a high level of interest. And then after establishing interest, we asked them, what are some features in an app that you would find helpful? Design elements, key features, things you don't want. And that's given us a lot of impact on what an effective IMST app would look like and how it could be used to lower blood pressure. So right now, I'm doing a pilot clinical trial testing app-delivered IMST versus our standard laboratory-delivered IMST. Here we're going back to our tried and true 30 breath per day protocol. And we're hoping that IMST delivered via smartphone app will be equally as effective as IMST delivered in the laboratory for lowering blood pressure. If we see that effect, then we can move the app into sort of more real-world studies. If we see that the app is less effective, we have the opportunity to change it to try to improve its effectiveness or uptake and make it effective before it's launched kind of into public health translation and dissemination research. Once we do have an effective app, I think some important areas for future research that it would allow us to explore would be something like testing IMST in communities with lower access to healthcare. So at least in the United States, people from rural communities, for example, don't have a lot of healthcare access when there's not hospitals or clinics nearby. So something that can be delivered remotely that doesn't require them to travel to see a provider could be something that's really important to improve health in these sort of underserved communities. I think it would also allow us to have a tool to partner with physicians to work on antihypertensive medication management. So a lot of people diagnosed with high blood pressure take 2 or 3 blood pressure medications to keep their blood pressure under control. Potentially, instead of prescribing them 3 medications, they could be prescribed a lower medication dose or fewer medications along with IMST delivered through the app. That would be beneficial because there's a lot of side effects associated with polypharmacy. So if we can lower the medication dose, that would be helpful for people. And then finally, IMST delivered through an app would allow us to perform the long-term trials on disease prevention that are the highest level of evidence that IMST can lower cardiovascular disease risk. So we have a lot of strong evidence on cardiovascular disease biomarkers, but we haven't performed large enough or long enough trials to see if we actually can lower the number of heart attacks or strokes people are experiencing. So with the app, you can have people performing IMST for multiple years and actually look at long-term disease outcomes. So I see kind of this mHealth approach as a real new frontier for this area of research that will both get it out into the real world, kind of find out additional ways it's useful, and fully establish the health benefits of this intervention. So I'm just going to close here with a brief summary of everything I talked to you about. Hopefully, I've shown you that high resistance inspiratory muscle strength training, or IMST, is a promising lifestyle approach for lowering blood pressure and improving vascular health, with the potential to reduce cardiovascular disease risk. It likely has some benefits on other physiological systems, not just the cardiovascular system, such as cardiorespiratory exercise performance, and maybe even brain health as well. Because of its excellent safety profile and potential for efficacy, as well as its low burden, it's a strong candidate for translation into public health. So there's a lot of future research that needs to be done on dissemination and implementation. And we have a lot of additional studies that are needed and ongoing to further understand this intervention. So hopefully over the next few years, I'll be able to tell you kind of some updated results, and we'll see kind of what's going on in this area of research and if there's more benefits than I've been able to tell you about today. So in closing, I just want to thank the long list of collaborators who helped with all this research, as well as the funding sources. I want to thank all of you for attending today, and I'm looking forward to answering some of your questions.
Thank you, Daniel. That was such an informative, insightful presentation, and really illustrated all of the hard work that you've been doing to date and will be doing in the future. So thank you very much. I would like to invite anybody to put any questions in the Q&A section, and I can read them out for Daniel to answer. I just wanted to kick off the question and answer session, if that's okay. Were you able to glean any qualitative feedback from this study? For example, when the participants came back at the 6-week follow-up. It's just interesting because as you talk about compliance, we're constantly looking in healthcare for ways in which to entice people to continue to do or take medication. Did anybody say that they really wanted to get back into IMST or anything like that?
Yeah, so we did have had multiple people who have been interested in keeping it going. Some people who went and bought their own devices after they completed the study so they could keep doing it. And in the study I'm doing now, where we're comparing to aerobic exercise, we actually were having an issue with people not wanting to sign up because they don't get to choose what group they're in. And they want to do IMST. They don't want to necessarily do aerobic exercise. They want the new exciting thing. So as an incentive, everyone who finishes that study, we give them their own IMST device so that they have the ability to do it once the study's over. And that's helped us a lot with recruitment, people knowing that, okay, in the end, I'll be able to try this out at least. So there definitely is interest as well, kind of in keeping it going.
Mm-hmm. That's really interesting. I love that people want to be in the intervention study.
Mm-hmm.
And I just had one other question before I'll read the ones from the chat. You did talk about obviously disease prevention, which is one of the buzzwords really again in healthcare. Your participants all had essentially above normal systolic blood pressure readings. Do you think that there is any application, or do we know yet whether this could play a role in preventing high blood pressure in the first place?
Yeah, that's a great question. So all of the studies I've done include people with a systolic blood pressure of at least 120, which is getting into that unhealthy range.
Mm.
Some of those studies with Dr. Bailey that were compiled in our combined analysis included young adults with a systolic blood pressure below 120, and blood pressure still went down in those participants. So that would suggest that it could be used for prevention kind of at young ages. It's something that you could start, and again, low burden, you could hopefully maintain it across the life course to help keep blood pressure below that
Mm.
sort of 120 cutoff where it starts getting into unhealthy ranges.
Right.
So we haven't done that prevention study yet, but the data we have suggest it likely could be effective for that.
Mhm. Which has huge implications long term.
Mhm.
Amazing. We've had a few questions, so if you're happy for me to read them out.
Absolutely.
First one is quite long. What are the suspected underlying mechanisms by which inspiratory muscle training exerts systemic effects beyond the inspiratory muscles on endothelial function and therefore blood pressure, including the potential influences on gas exchange, autonomic balance, cardiovascular function, and cardiopulmonary interactions?
Yeah, that's a great
Yeah.
question. So I'm going to preface it by saying that IMST is a type of exercise, and we don't even know how running improves all the health outcomes that it improves. There's huge studies going on in the United States to figure out how does aerobic exercise even work. So I think IMST is going to be similarly complicated and have a lot of different mechanisms through which it works. So that kind of as a preface, we have some good ideas on what is helpful and what's not necessarily the way it's working. So the person asked about autonomic balance. So that kind of means the messages coming from the brain telling blood vessels to constrict or dilate. So in people with high blood pressure, we tend to be in this sort of hyperconstricted state due to poor autonomic balance. Dr. Bailey has measured sympathetic nerve activity, which kind of is that constrictor signal, and found that in her sleep apnea patients, sympathetic activity goes down, which would be a good beneficial finding, suggesting that could be a way through which blood pressure is being lowered. Sleep apnea patients have a severely elevated level of sympathetic activity at baseline, so we don't know if we see the same effects in people who have kind of a more closer to normal autonomic balance. But I suspect that's one of the main mechanisms.
Mhm.
Something we thought that was going to be beneficial was blood flow patterns that occur while you're doing these deep resisted inspirations. So when you do aerobic exercise, for example, blood flow through your blood vessels increases, and that increased blood flow in the forward direction is a good stimulus for improving blood vessel health. We thought that would happen with IMST, but we've actually seen that when you do this resisted inhale, you get a reverse blood flow. So blood kind of being sucked back towards the heart. Generally, that is considered negative for blood vessels. So we were sort of surprised to see that happening acutely and chronically having these beneficial changes. Now it's really only 30 breaths, so it's a very small signal. So potentially those reverse blood flow patterns could be beneficial at such a small dose. That was an interesting finding that we're following up on, but it's definitely not a kind of large forward increase in blood flow like I thought it may be. And then one of the other key mechanisms that I think it is something released into the circulation while you're doing IMST. So doing aerobic exercise, large muscle mass activity, the active muscles release a lot of things packaged into extracellular vesicles, just little signaling packages into the bloodstream that can impact the whole body. We have some preliminary data suggesting that IMST can do the same thing. So the diaphragm and other respiratory muscles may be sending signaling molecules out there that can have beneficial effects really systemically. So that's an exciting area we're exploring as well. And I'm sure there's other ways IMST works as well.
That's great, thank you. We've had another question about whether you've had any experience working with the pediatric population. And it says, can the devices prevent DCVD? I assume that means cardiovascular disease, but specifically in children.
Yeah, so we haven't done anything in children yet. There's some people who have interest in doing this with children experiencing diabetes. That's the closest we've gotten. Those studies aren't off the ground. So don't have any firsthand experience yet knowing the effectiveness or the acceptability in children, but we're trying to move in that direction as well.
Great. And there is research on IMST in the pediatric population, not necessarily looking at cardiovascular disease, but in general. Somebody has asked about the training protocol of 30 breaths a day, and essentially, I guess the rationale for that, because they've talked about doing it for 30 breaths twice a day.
Yeah, so the rationale for that, the 30 breaths per day at 75 maximal inspiratory pressure, is to try to make it a relatively time efficient intervention. Um, so, twice a day is generally done at 50% PI max, so it's a little bit lower of intensity. You do more repetitions to get a similar stimulus. With 75% PI max, 30 breaths a day, that kind of comes out to sort of a maximum training session. So we actually break it up as 6 breaths, resisted breaths in a row, 1 minute rest. Repeat that till you get to 30 breaths. And some of our participants, they can't complete 30 breaths when they first start the intervention. They have to work up to it. So it's kind of getting up to sort of the maximum training load that people can do on average for 30 breaths. So sort of the greatest stimulus we could give them with a lower time requirement. Like I said, I don't think we don't have any evidence that that's like the magic training protocol. And we're working to manipulate things to see, what is the best training protocol, or are there different best protocols for different types of people, to be determined. But we just thought that 30 breaths once a day, higher training level, would be easier for people to adhere to.
Mm-hmm. And actually, I'll go back to the next question, because somebody mentioned what you've just touched on. They said, will future research include different intensity or resistance of IMST? They were talking about your breaths, where you've spoken about your future project looking at 15, 30, 45.
Yeah, so the goal is to ultimately be able to, yes, kind of change all the training variables to find the best training protocol. So with this one where we're changing the number of breaths, we're going to be looking acutely at what changes in the bloodstream and to see if that's a signal for the training benefits. And then in the future, instead of having to do these large clinical trials just to change number of breaths or intensity and see what happens, we could instead just do a single training session and look at the change in the blood signaling factors and use those to predict what the best training session would be. So that should allow us to much more rapidly test a lot of different permutations for training and then figure out what to launch sort of the next clinical trial on.
Mm-hmm.
So we're trying to come up with a more efficient way based on blood markers to kind of optimize the training.
Mm-hmm. Somebody has asked about the workings of the smartphone app for inspiratory muscle strength training. Is that something that you wanted to talk about, or you'd like me to, or you're very welcome to, if you send me your email address, then I can send you some details on the smartphone app for IMST. That's probably easier to do it that way. Moving to
Yeah.
the next question, somebody has asked if there's any support for IMST for POTS and or syncope management that you know.
Oh, I don't know of yet. That would be an interesting future area of research. I'm not aware of anyone doing that yet.
Okay. And then somebody has said, Dear Professor Daniel, I hope you're doing well. I would like to know your opinion on the combination of aerobic exercise prescription and IMST in patients with chronic heart disease. Do you believe that this association offers additional benefits compared to IMST alone?
Yeah, so one thing I haven't said yet is that I still think aerobic exercise is better than IMST. If you are already doing aerobic exercise, don't stop and just do IMST. While we've seen really good cardiovascular benefits, IMST doesn't do things like improve bone mineral density or help with weight maintenance or blood lipids, which are things that aerobic exercise does. So I look at IMST as if you're not active, this is better than doing nothing. And if you are active, don't stop what you're doing, but add on IMST. Um, we haven't done the study yet where we actually combine exercise and IMST together, but when we've recruited people from Boulder, Colorado, they tend to be very physically active people, not necessarily representative of the um, standard, more sedentary population. So since we see benefits even in these people who maintain their regular physical activity program while they're in our studies, I think there are combined effects, and that IMST, because it is such a unique level of respiratory effort, does add on benefits. So extrapolating that to, I think it was heart failure. I can't remember what the exact population was, but I do think it will have combined benefits when done together in patient populations.
Mhm. The two sort of work in conjunction, as you say.
Yeah.
Yeah.
And on a personal note, I do IMST and I run quite a bit. So
Yeah.
I I personally think there's benefits of trying them both.
So, yeah.
It's low burden, so you're not losing a lot, even if the benefits are maybe somewhat muted if you're already doing high levels of other physical activity. But that's
Hmm.
definitely on the list of future research to do.
Yeah. And I think the last question that we have is, can expiratory muscle training have the same benefit?
That's a good question. So I'm going back to Dr. Bailey again. She did a study looking at inspiratory and expiratory, and also kind of looking at large versus small changes in lung volume. So do you need to have a full breath, or does just the pressure, is that kind of the most important? And she saw that both inspiratory and expiratory have similar blood pressure lowering benefits, and it seems to be mostly related to the effort the muscles are producing and not necessarily the a large breath in or a large breath out. So based on that, we think expiratory training would probably be as effective. Um, I think it tends to be a little less comfortable for some people, so we focused more on inspiratory as something that we thought would be more acceptable. But from what we know, expiratory would also be effective.
Hmm. That's an interesting concept, given the kind of the focus of different muscle groups that you generally associate
Mhm.
IMST with versus EMST. But interesting to know that they both are maybe having a similar impact.
Yeah, it was a very interesting study that Dr. Bailey did.
Okay, one to look up. I think that's the last of all the questions. So thank you so much again, Daniel. That was honestly really insightful. And I hope everybody has learned a lot, and it's given us food for thought for the future of IMST and its applications with cardiovascular health. So yeah, thank you very much for your time, and have a good afternoon.
Yeah, thanks for having me.
Thanks, Daniel. Bye.